We go. Hi, everybody. Welcome to the October 2024 VTC Wellness Medicine Journal Club series. This session is focusing on drowning. We're going to cover a drowning WMS guideline, and then we're going to also cover an associated article. But we're going to go in reverse order to what I just said. We're going to start off with an article presented by one of our residents here, Emily Schaefer. I'm going to hand off, kind of mute myself, be in the background. I'll be in the chat monitoring. If you have any questions, I'll try and share it with the speaker. Take it away, Emily. I'll share screens enabled if you want to do anything.
Awesome. Thank you so much. Fair warning to everybody. I am at a campground and I have limited Wi-Fi and may go in and out. And if you hear people in the background, I'm at residency retreat. So people are having fun in the room next door. But I'm going to be talking about drowning, specifically in water resuscitation performed by both lifeguards and laypersons across a mannequin study. So the first thing to talk about is kind of why does this matter? And drowning causes 500,000 deaths annually, with a large component of the victims of drowning being children and young males. Drowning victims often have poor outcomes with high morbidity and mortality, and early ventilation is one of the few things that has been known to improve outcomes in drowning victims. It's a primary focus in the resuscitation for the AHA, but the AHA has no strong stance on whether we should do in-water resuscitation versus extraction and then ventilation. So previous research has demonstrated that in-water resuscitation could be done effectively, but it was performed in a pool with 3 highly trained lifeguards on mannequins. So the sample size was small and it was difficult to extrapolate to a greater population or to extrapolate to any open water or large swims. The paper itself was written by a group of German physicians. The main author is a German anesthesiologist, but he's done several similar research articles and other studies with water-based rescue, including helicopter water-based rescue and water-based rescue with efforts to initiate early compression. So a group that is highly involved in how to improve outcomes in our drowning victims. Their hypothesis, kind of what the article aimed to do, was assess the effectiveness of ventilation and water rescue with simulated water-based rescue performed by half trained lifeguards and half lay people. So it was a non-blinded, randomized crossover study, and the inclusion criteria included physical fitness and good swimmers, as well as training in BLS done within the last 6 months. Physical fitness and swimming capabilities were based on the interpretation of the volunteer. So the lay people were just people who said, I think I'm physically fit, and therefore I'm going to participate. There was no formal assessment of their swimming abilities or physical abilities. The rescues were performed in an indoor pool for safety of the participants. There were 21 lifeguards and 21 lay people who were asked to perform a rescue of mannequins with a 50-meter swim across an indoor pool with instruction given to 2. They were instructed to give 2 rescue breaths every 10 seconds while doing in-water rescue. So as far as their methods, they were asked to do ventilation. They were asked to do 1 swim with ventilation and 1 swim without ventilation. And of the participants, they were asked to do that in no specific order. So the order, whether they would do ventilations first or no ventilations first, was computer generated and totally random. And the mannequin was rigged to imitate the approximate buoyancy of an unconscious human body. And they used the way the mannequins were designed, they would not retain water and get heavier as the day went on, which was, I think, important to try to control your swims as the day went on. They measured tidal volume, ventilation rate, and minute volume with each rescue. And they also measured the aspirated water into the mannequin's lungs after each rescue in the pool. They also had someone at the side of the pool counting number of submersions that was observed. And the primary goal was to determine if in-water rescue is effective. And it was measured by 3 primary outcomes: delay of life-saving procedures like CPR, aspiration of the victim, and physical exertion of the rescuer. Secondary outcomes included effectiveness of ventilation between trained lifeguards and lay people. And to achieve these goals, they measured rescue time, tidal volumes, minute volume, number of submersions, and number and volume of aspirated water measured after each rescue. Participants were interviewed immediately after each rescue to assess physical exertion of the rescuer on the mannequin. So what they found was that while trained lifeguards seemed to be capable of adequate ventilation with in-water rescue, lay people seemed to be not as able to perform this duty, and they also found it more exhausting to try to perform this while they were trying to extract the mannequin. A third of the lay people were unable to complete the 50-meter swim while giving rescue breaths, which led to delayed compressions and, in theory, would lead to adverse outcomes. There's unlikely a difference in time to CPR and adverse outcomes when performed by trained professionals. But there was clearly a difference in the abilities of the trained professionals versus the lay people. So as far as like what to take away from this study, I think the subjectivity and physical capability were a limitation for sure. I think it's hard to control for that, but I think the fact that there was no swim prior to the volunteers being able to do it, or any sort of professional, it was just sort of lay people saying, I think I'm physically fit and so I can do this task. I think that could have been controlled for. The level of exhaustion was subject to a lot of subjectivity, and could people have done better in the first swim than the second due to being tired from already having done a 50-meter swim with a mannequin? Those are all sort of limitations of this kind of study. I also think there could have been a lot more participants. The number of participants, I think, limits the study. And the fact that it was done in an indoor pool makes it hard to extrapolate to any sort of whitewater, moving water, or lake or cold water environment where the rescue might be more difficult than a warmed indoor pool. And those were kind of my takeaways.
So there's a question in the chat by Douglas. Emmy, great job. I've been monitoring the chat, and Douglas was the first question. So question was, how did they provide the rescue breaths? So how did the lay people and the lifeguards give rescue breaths during the study?
That's actually a good question. I think it was, and I maybe took this for granted while I was reading it. I thought it was a BVM.
This study was actually done, they were trying to actually get a larger sample size than a prior study. So this study is actually larger than the prior. And you'll see in a lot of environmental and wilderness medicine studies, there's like 3 people. They're not large sample sizes. And you get most of your sample by giving med students pizza and then letting them be the simulated victims. So
it would work on residents too.
it would work. It might still work on me. It had to be good pizza. So this one, they actually based it on a prior study. That prior study, they did like mouth to nose. This one, they did mouth to mouth. So they really had to like turn the person to get to mouth. I've done this in my rescue diver course, in my wilderness lifeguard course.
No.
It is really hard to pop up, not dunk the person, give the breath, not completely lose all your momentum, and then keep going. It's hard. I'm a decent swimmer. I'm not like great, but like it's a pain in the butt.
Yeah. This is a so this was done for sure, mouth to mouth was in this study with mannequins.
So of course that Chris, I can't remember if you were there. You've been to the wilderness lifeguard course that Seth runs, but the one when he came up to Steph's lake house, they gave us this little plastic BVM style device. So it's usable in water, because most mouth-to-mouth devices have a plastic membrane, a plastic valve. This one has a plastic valve, most paper.
Yeah.
So it's useful in the water environment, because you can just like keep it on you when you get in the water if you need it. It's ready to go. You can get a decent seal,
think
but
they
again,
I feel like I remember reading that like people with smaller hands had a difficult time. And so maybe I interpreted that as they were using some device, but I'm trying to find it now in the article. And
I think it
don't.
was because they have a picture. Let me pull it up.
Oh, I see it. Yeah. Yeah, it's definitely mouth to mouth.
So they're talking about like the way that they taught the people to do the mouth to mouth, the small hands, because you had to like they tried to pinch the nose, support the head, and tilt the chin. It's a lot.
Oh, yes. Yeah.
It's a lot. I think that's exactly the one I've got. Yeah, that one's really cool.
I was thinking too about a 50-meter swim, and I was like, I think I would have a hard time just doing a 50-meter swim, let alone carrying a 70-kilogram mannequin plus trying to do anything else. So
Yeah. And one of the measures was like, do you think you could do this? Do you think you could go further? And most of them who were like, no.
it was
Um,
interesting
Of
because
the trainings.
of the lay people who did it, like the trained lifeguards kind of knew their limitations, but the lay people
Yeah.
were like, yes, I can definitely do this. And then 1/3 of them were not able to complete it. So
Yeah.
that was kind of interesting too.
It's
And
interesting.
also
My
with
question
the-
for the whole group of regarding this, like, first of all, like, why do you think this is, this, they even needed to do this study? Does anyone have a,
I think it's like, to me, I think the study is kind of interesting because it's one of the few things where I feel like we don't really have a guideline on as far as like, you know, and this may just be like my ignorance too, but when they were talking about the AHA kind of being like it's sort of a gray zone as far as our recommendations, I think when you're talking about pre-hospital medicine that you want everybody down to like lay people interested and lifeguards trained on, it would be nice to have a protocol where you say definitely do this or don't do this. And so trying to delineate like, is it actually helpful or is it detrimental to our rescuers would be great. Because it sounds like, and if you like kind of read through the introduction, it seems like it's sort of a gray zone where people sort of disagree on how helpful it is.
yeah, so this is the most recent, largest, like mannequin trial of the, of in-water resuscitation. It's not that new, but, does anyone know, I'm kind of like curious if anyone knows what the actual recommendations are, or if there are any actual recommendations on in-water resuscitation from any big organizations.
I should have looked them up, but I didn't.
So ILCOR, if you, the International Liaison Committee on Resuscitation last year updated their guidelines for resuscitation, and ILCOR actually has been on in-water resuscitation for the first time ever last year, and they essentially said that there was really not sufficient as evidence to be able to recommend in-water except for entrained rescuers, and should priority should be to bringing someone back to a boat or to land. And that basically their recommendation was to bring someone to a boat or bring them to land. That was somewhat controversial among like the drowning community, that became their recommendation, because I think now, what do people think as far as if you were to write a recommendation here based on this study, what would you recommend?
I feel like I would recommend like if it's like trained professionals should be comfortable doing it, but I think the like general consensus should be get them to land as quick as possible. But I think it would be interesting in the future to do a bigger study where you have people swim multiple distances and kind of figure out of trained professionals how far can they swim before this is like before there starts to be a discrepancy between there starts to be a dropout between the quality of ventilations given, to know like maybe there was no difference in a 50-meter swim. Would it be different at 100 meters? Would it be different at 150 meters? Would it be different in moving water? And I think that was sort of left to question because it was done in such a controlled environment. But I think that would also be hard to do because it would put the volunteers at risk. So
There's been a lot of, does anyone think of anyone else on the call here, particularly any of the student?
Starlink is trying so hard.
Is my internet bad?
It's the
You,
Bears. They're
you dropped
outside
off
again.
right at students.
No. Yeah. Would any of the students here, if you had to make recommendations based on this paper, would you recommend that lifeguards should do in-water resuscitation? Or should they just swim people to the shore? For professional trained rescuers, should they do it?
probably not. There was no difference. There was no difference in trained professionals, and there was a clear worse outcome in people who are lay people or maybe like professionals that are less experienced. And so probably just getting them to shore would be better, or to a boat or a more controlled environment.
So one thing to keep in mind for this article is their technique of specifically, you have a trained rescuer who in theory doesn't have any additional buoyancy versus most of their trainings, even in a controlled environment, they're going to have some additional buoyancy, be it a life jacket, PFD, or a lifeguard tube, or even just a mat rolled for like a lakeside wilderness lifeguard situation. And so there is, from that element, a way to get the body up and out of the water such that you're not automatically necessarily dunking them every time you give them breaths. And with the technique that they are using in this paper, you take that away. And so you don't have somebody with additional buoyancy, like you don't have that protective factor. Protective probably being a little bit of aggressive term, but I would say it would depend on what the ability is. Like if you are a trained rescuer, then I would think that you're not just swimming out there with nothing to help you, if that's what you are trained to do. And you are prepared to go rescue this person. And so to be able to get their head up and give them adequate breaths, because really the time to first breath is the biggest time barrier you need to get over in a drowning, is getting ventilations to them early. And so if you can do that in a manner that's successful with the technique, then I would say recommend it. I would recommend it. But for a layperson who can barely get to them, it's maybe wasting time for them to try and do rescue breaths if they may not make the swim back.
Sorry, I guess that my internet's super unstable. Sorry, but the so it looks like look at Ty's comment in the chat that he would say no because there's no evidence of superior outcomes. I think we discussed some of the limitations here of the study as well, and I always like to pose the question. Then there is a lot more evidence than this just one paper out there, but I think it's very interesting to consider. That we are somewhat operating in a low evidence zone, I think is what we see from here. Is when you recognize when this is an interesting study, should it be totally practice changing? What do you guys think? Like thumbs up or thumbs down? I'm kind of like in the middle on this thing. There's also inherent limitations to mannequin studies in these kinds of things as well, because the buoyancy is very different in a mannequin than in a human. Yeah, they weren't using buoyancy. There's a lot of limitations, but if someone wanted to design, and I always like to kind of wrap up a discussion of an article in Journal Club too, that if there are a lot of limitations, we think the article is not that greatest for answering the question. I think if someone could propose ways that they would improve it. So if you wanted to design a study that was better, how would you design a better study? Would anybody particularly want any of the, I'd love to hear from one of the students or something like that, if they could think of other factors or things they might want to design a better study.
I think I would have liked to see, I don't know that like having the like lay people who self-assess their own abilities, I think that adds a lot of confounding variables that's hard to control for. I would have liked to see trained professionals that had recently undergone the same class to kind of control for some of those variables, who all pass the same swim test, do 50 meters, 100 meters, 150 meters to kind of assess, like, you know, it's kind of gray, like, should we do it, should we not? But is there a distance where we definitely should not, or we definitely should? Was kind of like what I was wondering while I was sort of reading through this article of, like, you know, if it's gonna be a long swim, and we know it's gonna be a long swim, do we definitely want to be trying to do those? Was sort of something I was thinking about. But
I kind of liked the self-assessment part because, you know, that kind of puts a little bit of the things that somebody's going to be like looking at someone drowning, and then they're going to say, what am I going to do? I bet I can go out there and swim and do that. Like they're kind of making a self-assessment in the moment at that time too, which, so I think that's kind of interesting to consider in that standpoint, that someone is making an unrealistic self-assessment. I think it's just kind of, I think it's sort of interesting to just think that people make really unrealistic self-assessments, you know, like that's the thing is that they overestimate their abilities. And we see that come up in some of the epidemiology of drowning too, that people massively overestimate their swimming ability in a lot of situations, and which actually leads to drowning in many cases too. It was mentioned that as we kind of transition to the CPGs, you'll see that there's a Turkish study where, you know, it was up to 20% of drownings were actually would-be rescuers, that people trying to rescue other people were like end up drowning themselves. So we know that it's quite common that people will overestimate their swimming ability and try to go jump in and save someone when they shouldn't. Certainly
we
not
had a costume party at 8:30 for retreat.
Yeah. So it's quite all right. I can take over from here,
We'll
Emily.
get dressed up.
Yes.
Okay.
I do
Thanks
have
for
a
presenting. Good job.
Yeah.
It
Thanks,
was,
Emily.
job, Emily.
Thank you all for including me in
Yeah.
this journal club, and I look forward to working with you in the future.
Yeah.
Thank you.
All right. Pictures of the costumes.
Yes.
I will. Thanks.
I do have a question
right.
for Kevin, Kevin Watkins, wherever you're at. You said rescue buoy in water where rescues actually happen. So if you were to design that study, what kind of water would you pick?
I mean, I think ideally you pick multiple different kinds of water, but I think it would also depend a little bit on your area and where things actually happen. If things all happen in a swimming pool, then fine. But, you know, reading the study, it looks like there's multiple steps away from what is reality in a lot of cases. So it's pretty hard for me to sit and read the study and say I can extrapolate this to, you know, the real world on a beach or a river or wherever else. Because this pool water is going to be vastly different than, you know, those scenarios. You know, they're talking about like some of the subjective fatigue in that, and this is in pool water. This is not in more difficult water. So I think making it as realistic as possible for a trained professional that may have some of these like rescue buoys. But I also think, you know, how many lay people are going to actually have rescue buoys or other things. So I think realistically speaking, that'd be two different groups that you would actually want to look at overall, because they're, you know, what lay people carry around rescue buoys.
Yeah, I think, you know, you're looking at like very diametrically like opposing very different populations, right? So a layperson bystander rescue versus a lifeguard or professional rescuer, right? Like they are very, very different. I think this kind of interesting that there wasn't a bigger difference between the two, although you could say that the swimming ability was seemed to be significantly worse among non-professional rescuers. But it's very interesting. I've been contemplating a new design of this study for a while. Myself, I'm probably going to do another mannequin study in different water environments, looking at volume of aspirated water and things as well. I'm tentatively looking at doing this in a swiftwater environment too, as well, with people wearing life jackets, because that's been a hot topic and been very popular in the swiftwater community now for a while, about the possibility of rapid deployment of rescue breathing in a swiftwater environment by pulling someone onto a kayak, or someone's wearing a life jacket or things like that. So we may, if anyone's interested in this kind of research or doing another study that's like this and thinks they can do it better, you can email me after this thing and we can talk about doing the study, because it's so we've been talking to some folks about some funding to do this study, basically. So
I think it's kind of nice that they started with a pool. Like I like to think of it as like a proof of concept almost. Like let's say when Carver and I did our marine medicine conference in San Diego, like with the San Diego Beach lifeguards, like Baywatch, they're awesome. By that time I got to the simulated victim out past the surf, I was pooped. I was like, I'm done. Poor guy, they're dead. Because getting through the wave, getting through the surf, I was like, okay.
It's super
Come
hard.
help me.
I've got some, when I get into my presentation for you guys, I have some good footage of someone actually doing this, and you'll see how impressive it really is, particularly when you consider the context of this article. So I think
we can definitely transition. I'm going to hand it off to Chris. He's the lead author of both the committee that runs the CPG for WMS, and he's the lead author of this CPG. So I'm going to hand it off.
Yeah. Hey, Chris, this is Eric Hawkins. Can I just interject something?
Yeah.
So just so we do this in our journal clubs a lot, where we bring up, the actual terms for this. And just so people are clear, they're listening, this to me was an efficacy study. It shows that it can be done, as opposed to effectiveness, which is where we apply this to the real world, which is what I think people are bringing up limitations for. But I think the great thing about Journal Club, the way that we do it, is we always bring in these specific terms, so that way it's just a good way to review it. But I think everyone's comments are spot on. But it's hard. You got to demonstrate that you can do it first, just like Justin was saying. But just to bring the terms in.
Thanks, Eric.
Yeah, I mean, this is a perfect example of what you see early small pilot studies of things that are, I think that it provides a good starting point. There have been other studies similar to it. They've all been pretty small, and I think it just is paving the way for more research into this, which I think has the potential to be very impactful. So. Very good. Thanks for that, Eric. That was very salient. First of all, I'm going to apologize to everyone for my unstable internet connection. So I'm Chris Davis. I am with Wake Forest University, emergency medicine, the Wilderness Medicine program there. My primary research interests are in drowning and other so swiftwater rescue, whitewater, and technical rescue. I am currently deployed to Western North Carolina with one of our mobile disaster hospitals, and I've been kind of in and out for a while up here since the hurricane, and I have a pretty poor internet connection via Starlink, which is the best thing we have right here. So my apologies if things cut in and out. Feel free to ask any questions, interject, discuss this at all with me during it. You can certainly ask things as well about the whys or the hows of any of the recommendations we came to in the practice guideline. So before I even get started, if people can do a raise your hand or something in there if you actually read the practice guidelines before this, not to just call people out. I'm just curious. You can raise your hand in the things. I'm going to refer to them specifically. Does anyone have a big takeaway point that they took from the practice guidelines? We had a few things we really wanted people to walk away from this document with. And I hope that your one takeaway wasn't what to do if a car is sinking in the water, because that's pretty specific. And that's okay. So I'm going to give you guys just an overview of drowning. It's kind of all based on the guidelines that we came up with in our in the clinical practice guidelines. There is quite a bit of evidence in the world of drowning for what seem to be efficacious and not efficacious treatments for drowning. We have a lot of evidence as to what helps to prevent drowning. We do not have a ton of evidence about some of the things that we recommend, though, that you'll see that we have recently restructured how we give our grading in the our strength of evidence. You'll notice in the new practice guidelines that have been coming out starting in 2024. We are now using a different evidence criteria that you will see things like a strong recommendation with then either high or low quality evidence for it. So we have a lot of our recommendations are strong recommendations with low quality evidence, which basically means that we do not have large randomized controlled trials and meta-analyses to support these recommendations. We do have things like case reports, case series, and then expert opinion. So, but we do almost all of our recommendations in this are strong. And they do come from an author group that has a considerable amount of experience in both treating drowning and in epidemiology and research of drowning. But if you'll read through our references, many of them are not what we would consider the highest quality evidence, simply because we do not have large randomized controlled trials of like interventions for drowning patients. So most of it is done sort of retrospectively based on outcomes and like, yeah. So let's see if I can get this thing up for you guys here. All right. All right, so you guys, you're able to see my presentation there? Kara, can you give me a thumbs up if you can see it? Okay, excellent, very good. So we're going to give you a overview of drowning here. I just say I do receive financial support from National Park Service, NIH, and then also am a member of Blue Ridge Adventure Medicine. I said in my kind of professional life, among my regular clinical work, I help run our wilderness medicine program here at Wake Forest and do quite a bit of technical rescue training, disaster medicine, and other kind of responses here in Western North Carolina. This is here at Pilot Mountain with one of our former fellows, Chris Peluso. Work quite a bit in swiftwater rescue. This was from the Gauley River, which wraps up its recreational releases this weekend in West Virginia. If anybody is interested in a really good time, you should go rafting on the Gauley River. And I work with the National Park Service as one of the facilitators and course developers for the National Park Service Swiftwater Rescue Management Program called SWIM, Swiftwater Incident Management. This was from our last course in April on the Colorado River at Lee's Ferry in the Grand Canyon. So super cool to get involved with in wilderness medicine. You can be doing stuff like this, which is super cool. I also still get my hands dirty on the helicopter with air care. So I still do go see patients outside the hospital. One big warning for you guys. I am going to have some graphic depictions of actual cases of drowning. I share these videos with lay people, with medical professionals and things, not as a way to be gory or graphic at all, but I do want you guys to see the reality of what drowning looks like if you are ever unfortunate enough to encounter this in your home, at the beach, or in the emergency department. To resuscitate a patient with drowning. It's gross, and I want you to have seen it before that you actually encounter it in real life. So, a historical perspective, this is the first known depiction of drowning that we have seen before. Does anyone see what's going on here? Does anyone? What does it look like these people are doing? So this is a depiction of two people holding someone upside down by their legs, shaking them, trying to get water. That show essentially the same thing continues to go on thousands of years later, despite having significant advancements in the understanding of treatment of drowning. That this primitive approach to it advanced significantly by the 1700s. There was a new treatment for drowning. Does anyone see what's going on here? So this is a drowning resuscitation performed on the banks of the River Thames. And what they're doing is administering a smoke enema. So a tobacco smoke enema was thought to be the treatment for drowning at the time. And that quickly became recognized to be junk science, pseudoscience, and was it went away. They thought it was the treatment for actually lots of things at the time, but there's only really one thing left from this, which is, does anyone know what the only kind of remaining thing from this practice is? The term blowing smoke up your ass is what comes from the tobacco smoke enemas. So although we have advanced a little bit in our treatment of drowning, I would say that we still have not nailed it. So all right, so have any of you guys ever heard these terms referred to as drowning? I mean, drowning seems very complicated. You could have dry drowning, passive drowning, flush drowning, secondary drowning, parking lot drowning is one that you hear all the time. Particularly dry drowning. You guys have heard this before, right? So I want you guys to take this and get this all out of your head. If you read the practice guidelines, you should say that we do have one standard definition of drowning, and that a big part of the guidelines is trying to have a universal definition for drowning. So could anyone say what that is? Can anyone unmute themselves and tell me the definition of drowning?
The respiratory impairment with submersion or immersion.
Perfect. Yes. So it's even to be more specific, this is of experiencing respiratory impairment from the submersion or immersion liquid. So the reason I emphasize the process is because when we are educating people drowning, we really want them to understand that they're dealing with a process that exists on a spectrum. And the thing that process, right, is that a process can continue, right? Or it can be interrupted, it can be reversed, it can be stopped. Okay, so we want you to think about this as an ongoing process, and your goal is to stop it as soon as you can, right? So if you allow a process to go run all the way to completion, you'll get a predictable outcome, right? And we can say the same thing for drowning. But if we stop processes early, you can have variable outcomes, right? If you stop them at different points. And we do want to emphasize that drowning is never dry. If we spend a lot of time with all of these different crazy ideas that things like dry drowning are a thing, or that you have to be worried about, dropping dead from drowning 2 days after you've been in the water, you're really missing the point that drowning is a very preventable condition that needs to be treated with some very simple steps. By adding all this extra terminology, it's very difficult to know what are we even talking about if we can't agree on the same definition. So prior to 2006, there were actually over 30 different definitions for drowning. And it's very hard to study something if you can't agree on what it's called or how you define it. So the World Congress on Drowning they ended up with the World Health Organization in 2006, releasing the definition that we use today. But despite that, it is still commonly misused, and you will often still see coroners or things assigning dry drowning as a cause of death or things like that, secondary drowning, delayed drowning. These are still being used. It refers to this idea that sometimes on autopsy, you don't see a lot of water in the lungs. And so this theory that it could be a laryngospasm, that someone can die without having a lot of water in their lungs and end up with dry drowning or drowning. Thing, right? It's a singular process. They can come out with different outcomes. And by adding all this extra stuff in as terminology, making it seem confusing, we're really trying from the actual important thing, which is that drowning is a treatable condition that is preventable. Okay, we have, just like any other medical condition, we've kind of settled on there's 3 different outcomes. So someone experiences the process of respiratory impairment from the immersion of submersion or liquid, and it can either be fatal, right? So that process goes all the way to its conclusion of death. It can be non-fatal with morbidity. Okay, that means that you drown, okay, and you survived, but you have some lasting ill effect from it, either brain injury or lung injury, okay? Or you could have a non-fatal drowning with no morbidity. So has anyone here ever perhaps experienced a non-fatal drowning with no morbidity? Yeah, I think that, you know, if you really if you get technical about it, a lot of people here have, right? So you've had a respiratory impairment, you probably had a cough, shortness of breath, things like that. But guess what? You got better, and you're fine now. And so, do you think we have good data on that patient population? No, right? So people get better. We don't know. They never present to medical care, or if they do, it is often misdiagnosed. The improper terminology is used, and if you ever do any big data from medical record reviews, that if people don't code things correctly in the chart, you will never be able to find these things even happen if they use the improper diagnosis codes and things. So we really don't know what the incidence of that is. It's probably, we assume it is much higher than what we see. So sorry, my chat is in the middle of my screen and I can't, let me try to get this out of here real quick. Okay, so if you look around the world, like we really want to ask this, so who is at risk for drowning? And based on this chart and your reading of the article, we can come to a few conclusions, right? So that among 1 to 14-year-olds, so young people, drowning is within the top 5 causes of death all over the world, right? So only a few places it's not. And then there's some places we just don't have a lot of data about it, but it's pretty much most of the world. It's one of the leading causes of death. So we know that the largest group at risk is children 1 to 4 years old. And those children are more likely to experience drowning in the home or in the home environment. Okay, they can drown in bathtubs, toilets, buckets, and backyard swimming pools are often places for that. Okay, it's kind of a bimodal distribution of drowning. Does anyone think of who might be in the next peak? Teenagers, right? Adolescents and young adults. They're more likely to have experience drowning in natural bodies of water than in the home, right? So if you think about if there's any other contributing factor that you guys could think of that might contribute to young adults making bad decisions in and around water.
Substances.
Yes, so alcohol, substance use is a huge factor. Boating accidents are common, and often lack of wearing a life jacket is implicated in that. And we know that it's very common, right? So in 2010, there were 12,900 ED visits for drowning. 20% were admitted, so that's actually pretty good. So like a lot of those people were okay and went home. It was 48% more likely on weekends, and we also know that the boating accidents involving alcohol and things were significantly more likely to result in drowning than if there was no alcohol involved. So the big takeaways there are wear life jackets, don't get drunk around the water, and be careful if you are a teenager or young adult, right? And did you think if there was a gender predominance one way or another, did you think there you would notice a trend? Do you think it's more males or more females? It's actually a disease that it's significantly more common in that particular adolescent age group among males. And you'll see that actually it plays out over and over in trauma and other things like that as well. And there's actually neuroscience backing kind of some of the decision-making processes that go on there. So what does it look like? Has anyone ever experienced someone drowning before, or seen it on TV? Where we've all watched. Is a quiet process where people silently slip away without much struggle, right? So this is an example of a 10-year-old boy that drowned that took more than 2 minutes to notice him sitting on the bottom of the pool, okay? Drownings in reality happen very quickly and quietly and silently. There's not screaming and thrashing and waving of arms like we've seen on TV. Hollywood's kind of done us a disservice there. So here's an example of, he said, say that you're the lifeguard here and you're watching this pool full of children, okay? And you're trying to find one of them, okay? You guys see any children that look like they might be drowning? See kids going in under the water, kids slipping in and out of these tubes. See, this could be pretty difficult, right? Thankfully, the lifeguard here has a really good eye and is able to jump in. And you see he has his flotation with him and makes him safe. The kid's fine. Okay. You'll see that in reality, it can be very tricky to recognize drowning. Important is you. This is another video you can see of a child that unfortunately drowns in a pool full of adults who don't notice this for several minutes around him. This is just an example of what it looks like when someone is experiencing drowning, and how, unfortunately, even in a pool full of adults, if someone isn't specifically watching and looking for something like this, it can go completely unnoticed. So what can we do to prevent it? So prevention of drowning it can be pretty simple. We've got great evidence that physical barriers make a big difference. So that's things like fencing around pools or pool covers. They're in fact required by many municipalities, things as well, as far as building code. And also your homeowner's insurance, if you have a home pool, will almost certainly require you to have that. And they know to make a big difference. Adult supervision of children around water is extremely important. There's all really just have someone that's their job to watch the children, and you should rotate through that position. Okay. There's been, unfortunately, plenty of cases of drownings where the adult has been on their phone and not watching specifically the children. And they've drowned basically while the adults are sitting right there. Wearing flotation devices when appropriate when participating in water sports. So life jackets and boating makes a big difference. And then also the presence of trained rescuers and lifeguards makes a huge difference. They not only in making rescues, but also in preventive actions. It's been shown over and over. You may have heard that there is a significant difference, and you have to know about what kind of water someone drowned in. There's always these board questions that pop up and stuff about, is there a difference between fresh water or salt water? Now, this was interestingly, the idea was come out of some studies here that I have cited here. You see the years on these, 1953, 1947, where they instilled large volumes of salt water and fresh water into the lungs of dogs. Okay. And this 1967 is the earliest, or the latest article we have on this. And they put over 30 cc's per kilo into the lungs of these dogs, repeatedly lavaging them. And we're able to see differences in osmotic gradient and things like that there. In the reality, we have not found any clinical, like patient-oriented outcomes where we see any difference in outcomes or anything that has to do with the type of water when it comes to actually the patients we see. So it doesn't matter whether it's freshwater, salt water, it makes no difference at all. So what is actually going on during the drowning process? Well, we all start out alive and well with breathing normally until we are then submerged underwater or immersed in the water. Okay. It starts with this shock and surprise. So if we go into the water, anyone ever jumped into a cold lake before? What happens at first, right? We panic and we activate our sympathetic nervous system, which results in a gasping and tachycardia and hyperventilation. Unfortunately, it's for some people that are immersed in water, they can aspirate water, and that will kick off this whole drowning process really quickly. If you are then lucky enough not to have that happen right then, you will eventually tire out, be unable to swim anymore, and you'll go underwater. Okay. Once you go underwater, you will, at that point, what can you not do? Well, you can't get any oxygen, you can't breathe. So as you are underwater, whether or not you're aspirated water, either way, you're not getting any oxygen. So your oxygen saturation begins to fall. Okay. So our oxygen saturation starts to fall, but what's our primary driver of breathing? Well, it's not our oxygen saturation, right? It's our CO2 levels. So simultaneously, our CO2 level starts to climb. And eventually our CO2 will get so high, we will involuntarily need to breathe, okay? That will happen before we lose consciousness, okay? Have an urge to breathe, we'll open our mouth, we'll try to take a breath involuntarily, and we'll get nothing but water. Okay, so for any of you that have scuba dived before, if you get water in your mouth, you're trying to clear your regulators, you have a protective reflex there. You have two protective reflexes, in fact. If you get the water in your mouth, what does our body normally do to clear stuff out of our mouth to keep it from going in our airway? Well, we swallow, right? That's what our gag reflex is for. We either swallow or spit it out. So we'll ultimately swallow a bunch of water. And then some people then will have, as the water gets down to their lungs, that will kick off a cascade that we'll talk about a little bit later. But ultimately, regardless of what's going on there, what they're not getting, well, they're not getting more oxygen. So their oxygen will continue to fall. And as it falls, they will begin to convulse and lose consciousness, then ultimately begin convulsing. At that point, once convulsions begin, you are death. And if that process, remember process, we're saying here is not reversed, you will die within 10 minutes, typically of the process starting. Okay, so and that's the process of drowning that we discussed. So really what's going on here is going from alive and well to dead. And it all has to do with what? It has to do with their oxygen saturation. Okay, so we can, and if at any point we reverse that process by adding oxygen back into the mix, then then we can reverse that process and we can save them, okay? But the further down the process you get, the more injury occurs, if that makes sense, right? So one of a great example of this process is something we call shallow water blackout, okay? So these charts are really interesting. So if you guys ever had breath holding competitions or heard about breath holding competitions and stuff before, normally we describe under normal circumstances, your CO2 will trigger an involuntary breath before our oxygen level gets low enough that we can lose consciousness, right? That will make us surface, take a breath. That's why I can't sit here and hold my breath until I die. I'm just sitting here, right? I will just lose consciousness and involuntarily breathe. Okay. But in reality, right, I just cannot physically hold my breath long enough under normal circumstances that I could black out as a result of it, because I will involuntarily have to breathe. However, what if I hyperventilated and got my CO2 level so low that slope does not cross until under the point at which my SpO2 gets so low that I lose consciousness, right? So if you were to hyperventilate before going underwater, you could drive your SpCO2 or your PaCO2 so low that you actually will black out before you have an urge to breathe. So this is what can cause shallow water blackout, and is a reason we should encourage people not to hyperventilate before free diving or having any breath holding competitions, because we have actually seen a non-insignificant number of deaths from people doing this, hyperventilating, going underwater, blacking out, and then dying. So considering all that we just talked about hypoxia and all that, do you consider drowning to be primarily a lung problem or a brain problem? Well, I would argue that we should really think about drowning as a brain problem, okay? What we're trying to do is we're trying to resuscitate and save their brain, okay? Well, yes, in fact, the lungs are important, right? The lungs are how we get oxygen to our brain, but if we primarily focus on their lungs, we're missing the point, right? We only have minutes to save their brain. Their brain is not very tolerant of hypoxia, okay? And depending on our metabolic activity, we have that 10 minutes to death. Can you imagine a situation where that could actually be accelerated or be a lot faster than that? What if someone was metabolically exhausted in overdrive, high heart rate, huge metabolic demands before they began the drowning process, right? That could really accelerate this process entirely, right? So think about drowning as a brain problem. Why is that? Well, it's important what's going on in the lungs. So if we think about our alveoli, right, there are little air sacs that we use to exchange oxygen, and they have to be open. And and they have to be able to exchange gas across them, right? And the biggest thing is they have to stay open. So the thing we're saying there is surface tension, and we have something very useful in our lungs called surfactant that is what allows them to stay open like that. If we mix water with surfactant, we wash it away. And we begin to, if we then have atelectasis or collapse of those alveoli, well, we can't ventilate them. And then we kind of end up with a series of problems, okay? So as we have hypoxic alveoli, for whatever reason, we cause a shunt, right? So a shunt will cause a VQ mismatch, right? And then we have this exacerbated hypoxia because now it's not getting perfused either. So we and now they're becoming ischemic, okay? So what happens to ischemic tissue? Well, it gets leaky. Its cytokines get involved, all kinds of things happen like there, and then they get leaky and they have injury and the cells die, okay? And furthermore, the osmotic gradient essentially ineffective alveoli, okay? But what happens if you mix, so in addition to that, so like we take that surfactant that's all in our lungs and we add water in, right? So we've got water coming from outside, but then we also have our plasma leaking through that leaky capillary bed now because we've injured it from hypoxia and from the osmotic gradient and from the shunting, all right? So what happens if you take surfactant and then you mix it with water, right? So surfactant is found in your home. Anyone say an example of a surfactant we might find in our homes? Soap, right? So dish soap, right? Dawn is surfactant, okay? So if you mix surfactant with water and then agitate, what do you get? Well, you get foam, okay? So this is what we see in pulmonary edema, right? So when we see people coughing up pink frothy sputum, that's a mixture of plasma and surfactant from our lungs. Okay, and it's exacerbated in drowning because we have introduced additional water into the equation as well. So if you think about it, what's happened when someone's drowning is that someone has put Dawn in your dishwasher, turned it on, and now you're getting soap and foam going everywhere. And that's what you're going to see in a drowning patient. This is in a picture of a actual drowning patient in autopsy with a significant amount of foam coming from their nose. Okay, and this is what it really looks like in real life. So for any of you that have been unfortunate enough to care for a drowning patient, will probably people are usually note how remarkable the amount of foam is. This is a video of an actual drowning from a beach, and I want you guys to see a couple of things here. Number one, I want you to see what these people that are trying to help this guy are doing. Okay. So they think drowning is a lung problem. Okay. In their perception, just because it makes sense, they've got to get that water out of his lungs, right? They're focusing on his lungs right now. And does it look like it's working? Yeah, they're getting something out, right? They're getting foam out, and it looks like they're doing something that's helpful. But if we reframe to think about drowning as a brain problem, does it seem like what they're doing is helping? No, right? So they need to be giving him oxygen, okay? And unfortunately, we see this over and over and over in drowning, that people just like, I need to get the water out. I need to get the water out, right? And the reality is they have really probably not aspirated much water at all. And if they do, it's insignificant. And the thing that we need to do is save their brain by trying to give them oxygen back as fast as possible. So remember, we need to reframe and think about drowning as a brain problem, not a lung problem. Okay. So what should we do, right? So we pull someone out of the water, and what should we do? Okay. This is something that we need to actually require some public health and education, because the unfortunate consequence of a very effective public campaign on CPR in general has taught people what? So if you're at McDonald's and someone collapses, what is the approach? Collapses, unconscious at McDonald's. We go with CAB, circulation, airway, breathing. High quality chest compressions save lives. And we know that is true, right? That we know that is absolutely true. But what's different about someone that collapses in McDonald's and someone that's pulled out of a river. Okay, both of them are in cardiac arrest, but there's something very different about the first one. If we're playing the odds, the person at McDonald's had a cardiac arrest because they had a cardiac event, an MI, a dysrhythmia, and drop dead, right? Their oxygen saturation is probably 100%. And we have actually done in plenty of studies. We know that this person's oxygen saturation will stay good for a while, up to 8 minutes, in fact, before they really need rescue breaths. And so we know that we can effectively do chest compressions, circulate oxygenated blood for enough time to activate the emergency services, get an AED, and then when the show up, are they going to keep doing chest compressions only, circulate CPR? No, they're going to start doing breaths and stuff too, because you do need to eventually oxygenate them, right? But what's going on with the person drowning out of the river? Why are they in cardiac arrest? We already went through this. They ran out of oxygen, right? These people ran out of oxygen, and that's why they're in cardiac arrest. So do you think it's actually that helpful for me to keep doing chest compressions on someone and not breathe for them when the reason their heart stopped is that they ran out of oxygen? Right? So what we want to emphasize when patients have drowned is they do need an ABC approach, right? We need to start with airway, give them rescue breaths, and then go to CPR, right? So we see. And now, did anyone remember in our practice guidelines, what were our recommendations surrounding this about chest compressions only CPR? This was kind of a key and a controversial one. In fact, we went back and forth all over the place on this recommendation. Does anyone know whether we said that we recommended chest compressions only CPR?
So the guidelines say for lay people that it's better than nothing, but with rescue breathing, if you're trained in rescue breathing, then do that.
Yes. So we had a hard time with trying to with this one because we kind of we know that like expecting to ever encounter this, that you should learn how to do this, right? So so basically we say that if you're trained or able to know how to do it, we actually revised the wording a little bit, basically saying that if not that you have to be a professional rescuer or anything, but if you know how to do rescue breaths, you should. That's the thing. But I definitely would recommend that if you are around supervising children around water, if you're responsible for people swimming, something like that, even if you're not a lifeguard or something, you should know how to do and recommend knowing how to do rescue breaths. So the what about people wearing life jackets? Should we leave the life jackets on or take them off? We specifically we didn't have evidence for this one study about a chest compression effectiveness with the CPR with the life jacket on. Does anyone what that might be the result? You think you can do good chest compression with big inches of foam? No. So you should take off life jackets before doing chest compressions. If they're slide over the head like this, you need to pull them off. If they clip in the front, you can just unclip the front and be able to do chest compressions that way. So this is an example of the North Carolina Office of EMS protocol on drowning. Okay, and I think it's very important to see here that we took the time to do a few things here. So our recommendations here follow the WMS practice guidelines here, that essentially if someone is pulled from the water awake but has altered mental status, they should immediately receive 5 breaths by BVM or mouth to mouth. So this is the only place that we have mouth to mouth recommendation breaths in the entire North Carolina Office of EMS protocols. And the reason we have that is because we wanted to emphasize how important rescue breaths were to have done quickly and to leave space for people to be able to do that, particularly lifeguards or other people using these protocols. Does anyone know if the risk of bloodborne or communicable diseases, how high it is for mouth to mouth? Would you say it's low, medium, or high? It's actually pretty low. The risk for actually communicable disease transmission among mouth to mouth is actually pretty low. So I do recommend barriers. Those masks I put the link to before. The Seal Right is the best one I've used if you're going to try to be doing in-water resuscitation as a lifeguard or recommending that. It works very well. They're only $9. I have a ton of them. If anyone's ever around me and wants one, I will give you one. But also sometimes even just the simple like those keychain pocket masks are fine. They're not great. The valves don't work awesome. You have to, if they get wet a lot, you have to replace them frequently, but it's basically a sheet of plastic so you don't get chunks of vomit in your mouth or something like that, which is great. You can also use a shirt to kind of just pull their shirt up over their face to prevent like large amounts of vomit and things in there. You can use a glove over their face. You can like cut the fingers, like rip the fingers of the glove off with the glove in the mouth, put that over the mouth. That can be a effective barrier. But also, if I know this family member, friend, something like that, I would have no problem just doing mouth-to-mouth resuscitation because it's super important very quickly, and the risk is extremely low. All right, so if someone's awake and they have altered mental status, why do we go straight to 5 rescue breaths? Well, because we're going to assume that their altered mental status is due to hypoxia. Okay, we're assuming that hypoxia is the reason they're altered. Okay, now if they're unresponsive, before we do anything else, before we check a pulse, if we do anything else at all, they come for the water. We give 5 breaths and then check a pulse. Okay, so this is consistent with our practice guidelines, and it varies among other rescue guidelines. Maybe 3 breaths, maybe 2, but 5 is the one that we settled with, because we know the first one, based on some other studies, the first one is usually sucks. The last one usually sucks because you're about ready to start doing. So you get some of these things that, and it really emphasizes that we're hoping if we recommend 5 that you may get ones. So how long should we do CPR, or how long should we look for someone that's in the water based on the guidelines? So if you're at the pool and someone's pulled out doing CPR, how long are you going to do CPR? You're in the city, you're at a pool, you're at your house, you do that till EMS arrives. Okay, but what if we're in the wilderness? Does anyone have any idea if we're somewhere out in the middle of nowhere and someone is been pulled out of the water, cardiac arrest from drowning? We tried to keep numbers pretty simple. We went for 30 minutes. You can stop CPR after 30 minutes. As long as you don't think the primary reason that they're in cardiac arrest is from hypothermia, right? So you would have to really consider the circumstances there that led to it. But if someone has been submerged underwater for 30 minutes, you can transition to recovery. And because of some exceptional cases, we have extended the time to 90 minutes in cold water. However, I really want to emphasize these are exceptional cases. It is very, 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 very unlikely. So after much shorter than 30 minutes underwater. So if you're doing a rescue and you are going to do something that is risky because you want to, because you feel like you need to do something risky to save someone's life, you need to do that quickly. We develop irreversible hypoxia in 3 to 5 minutes underwater. So if you're going to do something high risk, don't do it at 28 minutes after someone's been underwater, right? So your chances of a good outcome are very low at that point. And certainly don't do it after 30 or 90 minutes, because at that point, we know that there's almost certainly no chance of survival. But the reason that people try to hold on to a lot of hope that there's some way someone could have an air pocket, they got very cold, and they had a lower metabolic rate stuff. And there are some remarkable cases of some children surviving some very prolonged immersions in cold water. But again, we have to say these are the exceptions, not the rule. Like for the overwhelming vast majority of people, death occurs very quickly after being submerged underwater. Complete recovery is fine, like absolutely fine after this. So in water rescue breaths can be effective. Now look, he's actually able to stand up though, right here. So this is one of the situations in which it's very, can be very effective. In the surf lifeguards or people very far from shore is where we recommend this as a really valid technique. Okay, but does it look easy? No. Okay. Mouth to mask ventilations are what we'd recommend if possible, but you can imagine, could you imagine trying to support someone, hold a mask seal, and then ventilate in the water? Incredibly difficult without, it's certainly almost impossible without flotation. This is another, unfortunately, very disturbing video of a child who's experienced drowning. But I think that a few very big take-home points here. So what we see here is a child who has been pulled from a river, and everyone around him is trying to, they're trying to help this kid. But again, their understanding of drowning is a lung problem, okay? And they're super fixated on this foam that's coming out of the child's mouth. Thankfully, his mom here starts to begin giving rescue breaths. But even so, is trying to just focus on getting the foam out of the mouth. Because even if you've had any medical training at all, you're taught clear the airway, clear the airway, clear the airway. But what is not happening while they're trying to get that foam out? Right, he's not getting any oxygen. He's not getting any oxygen. So what our recommendations are is for people to just ventilate right through the foam. Okay, so despite the presence of foam, you should just give your rescue breaths or bag valve ventilation through it. Right. If we think back to the physiology, what's going on is that dishwasher is still turned on. That metabolic process is still running. You still have atelectasis. You still have those that are experiencing further. They aspirated. It's also what we call non-cardiogenic pulmonary edema that results from that leaky vascular bed and the injury to their alveoli, mixing with that surfactant in their lungs, creating that foam. All right, so we want you to ventilate right through. Okay. What about AEDs? The incidence of VFib is actually pretty low among on. Well, if you have one, yeah, you definitely should, because it isn't a zero incidence, right? Certainly, depending on the circumstances, if someone was lap swimming, for example, and then they just lost consciousness while lap swimming, what might have happened? Well, this person may have had a cardiac arrest from, a dysrhythmia, which caused them to then have experience drowning. Okay, or they may have not drowned at all. In fact, they just had a cardiac arrest while swimming. If that makes sense, then we would certainly want to prioritize putting on AED. But the question often is it safe, right? And this person's wet. We're in a wet environment. Is it safe to use an AED? And in fact, the answer is yes, right? So you just want to dry them off enough to get the pads to stick, but you won't shock anyone around you. You won't shock yourself, and you won't cause any trouble by having a cervical collars. Put them on. Should we put them on people before we get them on the water?
No.
The answer is no. And generally always associated with some sort of obvious mechanism. Okay. And even so, in our priority, where does spinal motion restriction fall into our process when it comes, as opposed to airway, like getting someone's airway out of the water? Well, it doesn't matter at all about anything about their spine if they're dead from hypoxia. So we should not delay rescue at all for placing for you doing any sort of spinal motion restriction if it impairs a rapid rescue from the water. And all guidelines now discourage the use of hard collars whatsoever. The spine practice guidelines say there is no place for rigid cervical collars in wilderness medicine. So you pull them out of the water. We want to know how bad is this drowning, all right? So we can actually use a clinical from 1 to 6. That basically goes from mortality of 0, right? Say if they have a cough, they have clear lungs, no foam, they're gonna have 0% mortality. This person can be observed and continue on with their activity, all right? In general, as soon as someone starts to have any foam and crackles in their lungs, their mortality is now no longer 0. So you should you should seriously consider evacuating this person, because some people die. Some people do get worse at this stage. But if you just have a cough and no foam and no sounds, you won't really get worse. You're going to be okay. You do see a huge increase in mortality as soon as you start to see low blood pressure or lack of radial pulse. Why do you think that might be? Just a few moments to consider that. But if you imagine that graph we had before where it looked at the degree of hypoxia, once you start to get hemodynamic instability and as a result of hypoxic injury, we know you've gone pretty far down that process, right? So you now have an irreversible, a higher degree of irreversible hypoxic injury, right? Which gets all the way up to once they're in cardiopulmonary arrest. We know that they have experienced a significant amount of hypoxic injury in that case. But they still have a 93% chance, they only have a 93% mortality, okay, which is fairly in line with all comers in cardiac arrest. I see Sarah asked a great question here. And does the foam pressure gradient through the respiratory effort is also seen later in the process of drowning, where there's no longer respiratory effort? So that basically that's the question is, so can we see foam even when someone is apneic? And the answer is yes. So we will, even when we're mechanically ventilating people, we will see that. And when we kind of talk a little bit more about treatment, we'll see that there are some considerations we consider about their with that. So one of our great therapies, so positive pressure, it's an excellent treatment for drowning, right? On atelectasis and what we call these stiff lungs, the lack of surfactant. Okay. One thing to watch out for when using positive pressure is for insufflation of the stomach. Patients that have altered mental status, things you have to watch very closely for them for vomiting, because they have often swallowed quite a bit of water early in that drowning process. When they're have an intact gag reflex and they're swallowing water that enters their mouth, they often swallow a considerable amount of water, and vomiting is very common. So so be careful about that. That doesn't mean that people with altered mental status can't get non-invasive positive pressure ventilation. So that's your CPAP, your BiPAP. It's actually very effective. It works very well. You just should anticipate vomiting and just don't keep a very close eye on them. Don't, put them on BiPAP and leave the room. Someone should be with them if they're altered and they're on BiPAP after drowning. So, but it does work very well. What about supraglottic devices? Mannequin studies have basically showed that they can be placed well by lifeguards. That even non-ALS advanced life support personnel like paramedics and stuff that typically place these devices, they can be placed even by lifeguards. The problem is they may not seal with adequate pressure. Some of these people with injured lungs from drowning may require up to 40 centimeters of water of their peak pressures to overcome those stiff lungs and actually get air down to their alveoli, right? We know these supraglottic devices like the eye gel typically leak around 19 centimeters of water. So that doesn't mean that we can't use a supraglottic device in these people. Just know that might be a significant limitation, that if you are mechanically ventilating them, you may need very high peak pressures in order to get enough pressure to actually ventilate their alveoli, and you may be leaking before that. So this is one case where endotracheal innovation may be preferred in the hospital environment. I say, remember, very carefully choosing words, it may be preferred in certain circumstances. So how are we going to treat this person in the hospital? Well, once you put them on the ventilator, we're going to want to use a lung protective ventilatory strategy. That's going to be our typical. So the 6 to 8 milliliters per kilogram of ideal body weight, right? So that's a key thing for all pre-B medical students, right? This is not their actual body weight. So our lungs don't get any bigger the more weight you gain, right? So it's based on your height and based on whether you're male or female, and that gives you your ideal body weight and what size lungs you should have. Right? You're going to still try to aim to shoot for plateau pressures, right? That's where you do that inspiratory hold. And that it lets that big breath in, and you hold it, and then you let it equilibrate with the alveoli. So enough time to get past all those more proximal obstructions in their respiratory tree, and then see what the pressure their alveoli are actually seeing. You want to aim for that to be less than 30 to prevent barotrauma in their lungs, so popping alveoli causing an pneumothorax. And you want to keep their PaO2 between 55 to 80. And the one thing different, our recommendations will dissuade you from using permissive hypercapnia, which we often will use in other because if you because we want to yep, that is perfect. Douglas, you're saying that. That's perfectly. So that is since the primary issue that we're concerned about here is a neurologic injury, it is theoretically would be harmful to use permissive hypercapnia. So Doug, that's a great point. That is we don't have empiric evidence of this. We do not have randomized controlled trials where we randomize people to different PaCO2s. That is just the general consensus in the drowning community, in the critical care community, about caring for these patients. So if you're seeing them in the ED, should I get a chest x-ray on all these patients? They hit the door to kind of see what their lungs are doing. I bet it happens a whole lot. What do our guidelines say? I say that routine initial use is not recommended, and that our only thoughts on it are that might in tracking the development of lung injury over hospitalization. However, it has no prognostic value. So if someone might have a terrible looking chest x-ray, if they the chest x-ray won't help at all for your initial use. But we love to give people drugs, right? So drugs help for everything. We have medicine for everything. So what do you think about medicines? So antibiotics, right? This person just drowned in some nasty lake water. Certainly they need some antibiotics, right? And steroids help everybody with lung problems, right? So everybody that has a cough or URI, they get steroids. That helps, right? Helps COVID. Well, unfortunately, both antibiotics and steroids are not recommended because they don't seem to make any difference in people's outcomes. And then how long do we need to observe people? That's a great question. So kid comes in to the emergency department after experiencing respiratory from the immersion in the liquid. How long should we observe him? We can observe for 4 to 6 hours, and they may be discharged if they can be discharged after 4 to 6 hours if they have a normal mental status, respiratory function is normal, and they have not deteriorated, right? So, and this is actually based on some really good evidence. So there's some a couple of great articles here. So this is a great study from 2018 describing predictors of safe discharge for pediatric drowning patients in the emergency department. So if you have any attendings or anything that thinks that they need to be admitted to the ICU overnight because they experienced drowning, you can see there's a validated scoring tool here that you can refer to here in this emergency medicine article. And I've got some links to that here for you if you're a QR code snapper type people. And I can send them to you afterwards as well. Okay, I'm going to skip that. And we've gone on so long, so I'm going to skip this as well. How your conversations go with the MICU in these cases about holding antibiotics. For me, it's just a general philosophy. I give them my recommendations and I tell them why and why I didn't do something. And if once I admit them it's not my patient anymore. So they can, I'm not going to have that argument in real time. I'm just going to give them the information and be like, the guidelines do not recommend empiric antibiotics. I think a lot of experienced intensivists know this, and they would know that you may have, particularly in academic sites and stuff, you have sometimes fellows or residents stuff that they are not that knowledgeable about some of these more specific conditions and stuff like that. So I take that as an opportunity to educate people. But ultimately, I'm not going to have a knockdown drag out about giving someone antibiotics if they want. I mean, we give people antibiotics for the flu and stuff all the time. During COVID, everyone with COVID got Recefin. They got admitted. It didn't help, but that's what people did. So you got to pick your battles of what you're going to do. And if someone gets some azithromycin and Recefin for their drowning, we have no evidence that's going to be harmful either. So I wouldn't really, this isn't the hill I'm going to die on about it, but I would take the opportunity to educate people about this. That's kind of my approach. So I'm very specifically pick the hills that I'm going to die on. And there are a few of them, but this isn't one of them for me. Is there any other good? That's a great question. The big takeaways I want you guys to have, number one, is drowning is a process and it's a brain problem, right? And I gave you a few examples of why it's important that we try to educate people about it being a brain problem, right? Because it's gross, it's nasty, it looks like all this stuff is coming out of their lungs. But every minute we spend focusing all that is time that we're not giving them oxygen for their brain. I think it's also really important to think about the drowning a process, okay? And to get rid of all this of the things that really are important about drowning, which is preventing it, right? Which is supervising children, which is discouraging use of alcohol around boats and water, and also to wearing life jackets when appropriate, and supervising children. You know, these things we know make a really big difference. And all these sensational stories about, oh, this kid had dry drowning, get your kids checked for dry drowning, all this sort of stuff is really counterproductive, something that is actually a very big deal, right? It's one of the leading causes of death worldwide among children. We have some known strategies that are very effective at preventing it. And unfortunately, they get overshadowed by these sensational, rare cases that are often just misinterpreted information that is due to a lack of understanding of the process that's going on. We shouldn't wait to give breaths. If there's foam coming out of their mouth, we're going to breathe right through it, and we'll wear our life jackets. So that's what I want you to have as their take homes from this. Any questions? I don't want to use up any more of your time. It's been an hour and a half spending with me, but I'm happy to answer questions as long as you guys would like. Oh, I see some. What are some training and certifications you recommend for people new to water rescue? Well, it really depends on what you're interested in doing with it. So, you know, there's some great, if you are mostly interested in, you know, going swimming with groups in the, you know, in lakes and streams and stuff, if you're taking groups out or kids and stuff, there's a course from Starfish Institute called Wilderness Swim Safety. I have no financial relationships with Starfish Aquatics Institute. I just think their courses are fantastic. I do know all of the people in that organization and they are friends. So there is that disclosure, but I have taken the class, formerly known as Wilderness Lifeguard. And it's very good if that's what you're interested in. If you're a whitewater boater, I cannot emphasize any kind of swiftwater rescue class. Anything from like a very basic lifeguard class is incredibly valuable. If anyone here has taken any lifeguard classes before, are really eye-opening and stuff for how they can help. Oh, great! I see Kara dropped a link into it too there, and they may or may not have rebranded it yet, but it is going to be if it is not rebranded yet on the website, is going to be known. The same class is going to be known as Wilderness Swim Safety.
Hey, Chris, I got a couple questions if you have a minute.
Yeah. I sure do.
It's Doug Swart. I'm up in Maryland. Let me see if I put my camera on. I'm in my car. This is coincidence, but I just happen to be part of a group of medical directors trying to revise our state protocol for drowning for EMS.
Yes.
And currently, if you look at the termination resuscitation aspect of it, the state protocol does not allow field termination. Hypothermia, pregnancy, and drowning are automatic exemptions from field termination and require transport to at least an emergency department per protocol. And we don't think that's the right answer. And so we're trying to revise it. And so out of that, there's a question about the cold water drowning. And in your view, do you see any role for termination of a cold water drowning, or would you think they all ought to be transported despite the submersion or immersion time, in the specific time greater than 90 minutes?
Yeah, so I think that I'm sorry, some of your question cut out. I've got this bad internet here, but to kind of let me summarize back what I heard. So I think you said you're trying to revise your state protocols on drowning resuscitation, and that there's specific exemptions for
Yeah, you just froze again, Chris.
Rest of the termination criteria, the person isn't in persistent VFib, would be a candidate for ECPR or something like. I don't believe anyone in our ECPR program would cannulate someone after drowning, that wasn't hypothermic. I don't see there's any reason why you could not terminate on scene for a drowning, particularly if you, I don't know what other criteria you're using, but if you have, if you're using end-tidal CO2 criteria, if you're using rhythm criteria or anything like that, I don't see why you could not terminate on scene for drowning.
How about less than 90 minutes?
For if so, whether with the length of resuscitation or submersion time.
Submersion time.
So like I think it would never.
I'm sorry, Chris, you keep freezing.
So and I would that's
Chris, I didn't catch any of that. You froze the whole time.
yeah, it's not that great.
I
So
know.
so basically my summary is that I think that if the person is submerged in the warm water for greater than 30 minutes, I don't think you even need to start resuscitation. Meet death criteria, determination criteria just there. I don't think that the fact that they drown really portends any greater chance of survival that would preclude you from terminating in the field. So I think that field termination is reasonable, even with drowning. And the one caveat I would say is if you think that if the crew thinks there's any reason that they could be hypothermic as the cause of their cardiac arrest, that would be, cold water.
Yeah, this is only the cold. We're not worried about the warm water. I think that's easy. It's the cold water, prolonged submersion is our question.
That is a, I would probably default. Do you guys have a good hypothermia protocol in that case?
I missed your question. You froze again.
Oh, I said, sorry. Do you have like a good hypothermia protocol?
I mean, we have a hypothermia protocol. In these cases, I would assume that the hypothermia and the hypoxia from the drowning occurred in tandem, as opposed to the hypothermia first.
Right. And but that's the whole kind of the thing that we kept, like when we're having these conversations and the guidelines meetings, is that it's this theoretical thing that there's somehow, some way that they got cold enough before they experienced their hypoxia, right? So that they like somehow pre-chilled cold enough that they were already hypothermic before they suffered a cardiac arrest, right? So that's the only situation where you could even conceive of these cases being survivable, right? And we think that maybe it happens sometimes, right? Because we've had a few of these cases where people survive for long periods of time. But I truly think that's incredibly exceptional. And I think in the vast majority of cases of even cold water drownings, that people experience hypoxia and a cardiac arrest in 3 to 5 minutes before their core temperature changes at all, right? So
yeah, I agree.
Yeah, so that's I think it would be very reasonable to terminate, particularly outside of 90 minutes. I think it's very simple, very easy that you should probably not even attempt resuscitation after 90 minutes. And then, but in that gray zone of 30 to 90 minutes, it would probably be, oh man, I don't know if I could totally commit to that in this form to do in that case. But my gut feeling is that probably you're not going to miss any survivable cases in there.
All right. Thank you. The second question, and in the cases that are transported, so not terminated, that are in either arrest or extremis, should they go to an ECMO capable center initially even if it requires aviation transport.
Yeah, so your patients that are in extremis and have, you know, that they're having like evidence of severe lung injury.
Yeah, or in arrest that you decide to transport, whatever reason you decide to transport, should they go to the highest level ECMO capable center available in the region?
I would
First stop.
Yeah, because I think if you're in that gray area where it's cold, they're still in arrest and you decided to transport them, I think that the move would be to go to an ECMO capable center, because we know that, like, if there's an intervention that's going to help these people, right, that we would have to assume that the reason that this is happening is because they're hypoxic, because they're hypothermic, right? And so if that's the case, I think that transport to ECMO makes the most sense, because what else could your local hospital do that you're not already doing other than ventilate someone with 100% oxygen, right? Because if it's hypoxia that's causing it, then you've addressed that. If you've got an airway established and you're ventilating them, and then the only other thing you say that, well, they're gonna get a core temp, check potassium, say this person's actually viable, they're cold, and then we're gonna put them on ECMO, right? Like that would be that's what I would think that would be a reasonable strategy for those people, if that answers your question.
It does, and I agree with everything you said. As was stated earlier, as the author of the guidelines, I thought that this would be a good opportunity, for me to ask you about that, given that it's a current project that I'm, one of like 6 people working on. So I appreciate your thoughts and your comments and feedback on that very much. So thank you.
Anybody else with questions on or want to share any cases they've experienced personally or patients you've taken care of?
So, and also, Doug, you've been cutting it out. Feel free to reach out to me by email if you want to discuss this anymore. I'll be happy
Yeah,
to.
cool. I was going to, but then we had this like journal club thing that came up.
Oh,
So it was it was true and unrelated, but coincidence. But yeah,
perfect.
I'll do it. I do have a case. I do have a case that I could mention that's related to hyperventilation prior to getting in the water. I saw a young male, healthy, but had cervical disc disease and really loved to swim. But when he was doing a freestyle or crawl style, when he turned his head to breathe, it hurt his neck. And so he would hyperventilate, and then he was able to swim an entire length of a pool on a single breath. And of course, one day he was found, face down, limp, unresponsive in the pool by lifeguards who pulled him out of the water and gave him CPR and I think an AED shock. And then the county fire rescue came and shocked him a second time, and they got ROSC. And I took him to the local hospital where he underwent therapeutic hypothermia, which maybe was more, I may be dating myself, it was more in vogue at that time than it maybe is now. And
yeah, I certainly did it. Wow.
Yeah. You're showing your age there, Chris.
Yeah.
And then he recovered his neurological function, and he's actually a physicist, so he's like super smart guy. And no one could figure out what happened to him. And he got a lot of genetic testing, for prolonged QT and other things, and nothing was ever found. And so they put a defibrillator in his chest, and I happened to see him 2 years later, and when I interviewed him, and I figured out that it was extremely likely, couldn't prove it, but extremely likely that he hyperventilated and had the blackout from that, which none of the cardiologists or intensivists or anyone else that ever saw him ever even considered.
Yeah.
So I thought it was pretty interesting. And then he asked me, like, should I get the defibrillator taken out? And I'm like, no, hold on. Just change the battery when you need to and live with it.
With advice, I would never recommend someone take out their defibrillator.
No.
That thing in there, like, I mean, it might help you out one day. I don't know.
Yeah. You might have regular CAD and,
Yeah.
VTAC arrest.
Yeah.
You live long enough, right?
Yeah, absolutely. Very good. Well, it's been a pleasure talking. And again, if anyone has any other specific drowning questions, reach out to me. And if I don't know, I know some people that know even more about this than I do. So I'm happy to talk to them as well. So.
Well, I guess thanks everybody for joining. This is part 2 in our sort of kind of inter-journal club sub-series on submersion and immersion. So this past August, we had free diving. This session on drowning, and then November 20th, our upcoming session is with Dr. Moon of Duke University hyperbaric program. He's going to be talking with us about immersion pulmonary edema. That was on the docket for back in April, and that was when Zoom kind of crashed on me. So we reslotted that for November 20th. So then we can kind of figure out, oh, there we go. Make sure we kind of end up the mini series here, but happy to see the next month. Otherwise, I'm going to end the recording, and I'll see you next month.
I highly recommend Dr. Moon. He's brilliant.